Hello, everyone. I'm pleased to introduce Dr. Ryan Marek, who is an associate professor of clinical psychology at Sam Houston State University. He received his PhD in clinical psychology with a minor in quantitative methodology from Kent State University in 2017. He has been extensively involved in MMPI research, primarily in medical settings. Dr. Marek's program of research is focused on understanding how psychological factors contribute to medical outcomes. He currently has over 60 peer-reviewed publications, mostly focused on pre-surgical psychological evaluations, MMPI instruments, and how they predict various outcomes. Dr. Marek uses his research to help patients manage risk factors prior to and after surgery to help them achieve good outcomes, and has been awarded early career research awards for his work in pre-surgical psychological evaluations. He is also the lead author of a book pertaining to pre-surgical evaluations. In addition to his private practice, Dr. Marek's clinical practice involves supervision of assessment and therapy at Sam Houston State University's Psychological Services Clinic. And with that, I'll hand it over to Dr. Marek for his presentation, and I'll see you at the end, time permitting, to address any questions that come up in the Q&A box. Take it away.
All right. Well, thank you, Ben, for the kind introduction, and good morning to everybody. And I'm excited to be able to do this webinar with you all on the MMPI-3 spinal procedure candidate interpretive reports. And so we're gonna get going today. So just one disclosure, I do receive research funding support from the University of Minnesota Press as a co-investigator for many of the studies cited in this presentation. And as co-author of the MMPI-3 spinal procedure candidate interpretive reports, I also receive royalties on sales of the report. So if you're joining this webinar, it's ideal that participants have had some exposure with the MMPI-3. If you have not had exposure to the MMPI-3, Pearson does offer some really nice webinars on general overviews for the MMPI-3 that I highly recommend. And also some experience with pre-surgical psychological evaluations, notably in spinal procedure candidates. We won't be doing a full overview on pre-surgical psychological evaluations during this webinar. And just to kind of remind everybody of the agenda today, we're going to review the rationale and psychosocial factors impacting surgical results. We'll then move towards discussing research on the MMPI-3 in this population. Components of the MMPI-3 spinal procedure candidate interpretive report. We'll talk about a case example integrated throughout that, and we'll leave some time for questions and answers. I do have my contact on both the first and last slide of this presentation and in the handout. If we don't get to your question, you are always welcome to reach out to me. I tend to be a very responsive individual, and will do everything I can to answer your questions. So just kind of a broad overview of this population. When we think about spine surgery, we have to think about back pain more broadly. So back pain is experienced by up to 35% of individuals each year, and up to 85% of persons are going to have back pain at some point in their lives. So back pain is a fairly common phenomenon that most of us are going to experience at least once in our lives. And the good news is that most of the time, back pain sort of resolves fairly quickly. But for a subset of folks, the pain may continue unresolved. We're thinking it's about up to 10% who experience back pain will then also have some unresolved pain. And that leads them down the path to some conventional treatments that may include steroid injections, physical therapy, chiropractic, and you know, the downside with a lot of unresolved pain in the back leads to all these different impairments, sleep difficulties, difficulties at work, maybe not even be able to return to work, daily activities that we don't really think about too much, like such as using the restroom becomes or cooking can become a real chore. And it's when conventional intervention doesn't work is when surgical interventions start to become an option for the patient. And so one would think that after spine surgery, once the actual physical pathology is corrected, that most patients will no longer experience pain. And that is true for most patients. But sometimes, even though the physical pathology is corrected, spine surgery may not always be effective in reducing pain or improving functioning for some patients. Going through some research, for instance, insurance claims on 494 discectomy patients were analyzed, and about 28% of persons in that study reported some kind of unfavorable outcome. And about 80% of that sample pursued additional surgeries after that. So outcomes weren't universal per se. In another multi-site study, 460 patients were assessed 1 year post-op following spinal fusion. And this study included various different measures, including the Oswestry Disability Index, the SF-36, and other measures of pain and quality of life. And across these measures, somewhere between 47 to 61% demonstrated improvement, but only about 27%, so just over a quarter of patients in the study reported improvements across all measures. Again, speaking to the variability that a lot of folks may experience following spine surgery. The other thing that we're noting over the years are that the rate of elective spine surgeries has been increasing, and is thought to continue to be increasing as well. And medical expenses are certainly becoming more expensive year after year as well. And aggregate hospital costs have increased around 177% during these past 12 years. That exceeds $10 billion in 2015, which averages more than about $50,000 per admission. And so when surgery doesn't work, we often refer to this as a failed back surgery. You have to think about the costs associated with additional procedures. There may be new medical related problems that may occur as a result, which is extremely frustrating for the patient. The patient may not be able to return to work, which of course causes a large financial strain. The patient may develop quite a bit of anger, resentment, depression, and anxiety afterwards. And depending on whether or not they're doing any kind of opioid therapy, could also continue to increase the risk for opioid addiction. And so another option for patients could be the spinal cord stimulator. And typically candidates for the spinal cord stimulator include persons who are in the category of having a failed back surgery syndrome. It could also be a method for avoiding like a major spine surgery. The other good use for a spinal cord stimulator could be for complex regional pain syndrome. Other conditions where maybe like a very focused surgery may not fully correct the problem. And spinal cord stimulators are becoming increasingly popular. Around 20,000 are implanted each year, and that number is expected to continue to rise. Average cost is around $52,000 for the first 24 months. And they're not without complications. Somewhere between 20 to 25% of patients will report some kind of a complication associated with the device. And like spine surgery, spinal cord stimulator results could be quite variable. And if we look at like pain reduction, greater than 50% pain reduction, about 62% of patients will report a reduction in phantom limb pain and failed back surgery syndrome. 84% will report pain reduction in complex regional pain syndrome. So very good outcomes. But notice we're not necessarily close to 100% there either, that a lot of folks are not experiencing those. In a study of 100 failed back surgery syndrome patients, where they were given either a spinal cord stimulator or conventional medical management treatment, you look at about 6 months following the intervention, 64% of patients achieved a 50% reduction in leg pain if a spinal cord stimulator was obtained, whereas only 18% of patients reported a reduction in leg pain following conventional medical management. So spinal cord stimulator are quite effective, but they're not universal. Patients aren't universally going to have those good outcomes. And so we turn towards whether or not psychosocial factors are related to some of these variabilities in spine surgery and spinal cord stimulator populations. When you take a look at emotional functioning, patients who report having problems with depression-related symptoms tend to report suboptimal surgical outcomes. When we look at some studies, for instance, even with the MMPI-2, for those who have a history with the MMPI, MMPI clinical scale 2 tended to measure a lot of symptoms associated with depression. Those tended to be consistently linked to poor outcomes in spine surgery and spinal cord stimulator populations, and to a little bit lesser degree, scale 7 as well. But in broader research, other emotions have also been linked to more suboptimal outcomes. That includes things like anxiety and anger as well. When we think about the construct of somatization, those are patients who tend to have a heightened awareness of pain symptoms or experience pain in excess of that is expected, given the particular physical condition. We notice that patients who tend to have a little bit higher tendency in the somatization domain also tend to report some more diminished outcomes. And again, looking at the history of the MMPI, for instance, the MMPI-2 clinical scales 1 and 3 tended to predict patients who reported higher levels of pain following the procedure. That also included the classic 1-3-3-1 cotype as well. And so kind of moving forward, when we think about chronic pain as well, another construct that comes to mind is catastrophizing. And that has also been found to influence surgical results. And it's sort of like this belief that the injury represents the beginning of an unending or worsening event of traumas. And so catastrophizing tends to be associated with greater pain levels, higher opioid consumption, greater levels of depression, as well as poorer surgical outcomes. And substance use as well. So opioids can sometimes be regularly prescribed for spine surgery and spinal cord stimulator patients. Using old DSM-4 TR criteria, about 61% of chronic pain patients met criteria for opioid abuse, including more and more frequent medication prescribed, calling in for early refills, things like that. And although there is evidence that opioid therapy is indeed effective for managing back pain and spine surgery, studies have also linked opioid therapy to poor outcomes for both conservative pain management treatments as well as spine surgery treatments. And so substance abuse is certainly something that we want to look out for in a lot of these pre-surgical evaluations. And of course, more broadly speaking, interpersonal problems. And so significant others, for instance, can unknowingly reinforce a lot of the patient's pain and related disability. They may start taking over the patient's job or responsibilities at home, may reinforce giving the patient pain medication, encouraging rest while discouraging activity. So some of these factors could certainly play a role in enabling pain behaviors. The other thing, too, is that friends and family members may be more likely to pay attention to the patient when pain appears to be at its greatest, and then maybe not provide as much attention or ignore the patient at other times, associating a response there, a connection. And patients with some abuse history in their background as well also tend to be associated with diminished outcomes as well. And so understanding a lot of these interpersonal problems are also key to helping our patients have a good outcome. So I definitely want to talk a bit about the research on the MMPI-3 in these populations. And I think the best way we can start doing that is to talk about the history of the MMPI and talk about where we got to the MMPI-3 today as well. Because a lot of the literature that has existed in the past with the MMPI is going to be very relevant to today's interpretive reports. So we know that MMPI instruments have been among the most commonly used measures in studying and assessing psychological risk factors in surgical candidates, notably spine surgery. If we look at the literature across the board from both the MMPI and the MMPI-2, clinical scales 1, 2, and 3 have frequently been found to be associated with pre-surgical dysfunction and negative outcomes in back surgery candidates. And so scales 1 and 3 are measuring that somatization. Scale 2 tends to measure those depressive symptoms. But there are some problems with the MMPI and the MMPI-2, and that included some substantial item overlap, construct overlap that significantly limited discriminant validity, in addition to construct validity of the scales. And so there was some work done on the MMPI-2 that resulted in what we call the restructured clinical scales. And eventually, the alternative version to the MMPI-2, which is the MMPI-2 restructured form. And so studies over the decade have found promising utility in the MMPI-2 RF in this population. And to give everybody just a little bit of a background, one of the key aspects with restructuring the clinical scales included removing items associated with demoralization and specifically isolating and measuring demoralization and cleaning up the rest of the clinical scale so that its core constructs were retained. The MMPI-2 RF had demonstrated some better psychometric properties over its predecessors. It reduced item overlap within scale sets, and it became substantially shorter than its predecessor. Anybody who had been using or taking the MMPI-2 were used to the 567 items. It took quite a bit of time. The MMPI-2 RF reduced that by quite a bit to about 338 items. And when we looked at the MMPI-2 RF in spine surgery and spinal cord stimulator populations, we found quite a few things there. One is that the scales of the MMPI-2 RF demonstrated good reliability. And when you looked at validity within these samples, validity was very good. And so at its ground, it looks like a good psychometric instrument. It also established comparison group data. We had lots of patients who were able to generate comparison group data for, so you're able to take a look at your patient scores relative to others who are pursuing a spine procedure. And I think what was really great about some of these studies that we've done with the MMPI-2 RF is that we were able to use the MMPI-2 RF scales to predict various kinds of outcomes. And so it's a really rich literature right now with the MMPI-2 RF. And it's going to be really important because we're going to be able to use all of that literature from the MMPI-2 RF and apply it to the MMPI-3, which I'm going to go over in just a little bit. And moving towards the MMPI-3, the authors looked towards the MMPI-2 RF as a bit of an anchor, and the development of the MMPI-3 resulted in much needed updated normative data that's based on 2020 projected census data. The item content was reviewed, and a lot of the items had been revised and modernized as well. And it was an opportunity for expanded item content as well. And as a result of expanded item content, new scales were able to be produced, covering content area that the MMPI-2 RF didn't cover as well. These include things like eating concerns and impulsivity, compulsivity, and the introduction of the combined infrequency scale, CRIN. So these new scales were added to the test. Some scales were removed from the test. Things like aesthetic and literary interest and mechanical interest you'll no longer find on the MMPI-3. Other scales, such as the stress-worry scale from the MMPI-2 RF has now been broken into two more specific scales, the stress scale and the worry scale. And overall, when you looked at the MMPI-3, the scale psychometric properties, they look as good and sometimes even a little bit better than the MMPI-2 RF. So this essentially resulted in the MMPI-3. And it's a broadband measure. It contains 52 scales. You'll get lots of validity scale information, infrequent responding, different types of over-reporting, including over-reporting of somatic functions, and then under-reporting as well. And these validity scales are really useful in pre-surgical psychological evaluations. We have 3 higher order scales: emotional internalizing dysfunction, thought disorder, as well as behavioral externalizing dysfunction. Those trickle down then to the restructured clinical scales. Broken from there, you have 26 specific problem scales, 4 of which are in the somatic and cognitive domain, 10 internalizing specific problem scales, 7 externalizing specific problem scales, and then 5 interpersonal problem scales. And I teach personality assessment, and I always instruct my class that the MMPI-3 is not just a personality measure. It's a measure of psychopathology in addition to personality. And we also see those psychopathology personality 5 scales that are good domain measures for things like the alternative model for personality disorders. And when given via the computer or tablet, the test takes about 25 to 35 minutes to complete with a 4.5 grade reading level. And the good news with the MMPI-3 is that if you have been trained to interpret the MMPI-2 RF, you can use the same interpretive strategy with the MMPI-3. If you're used to using the MMPI-2 RF, the MMPI-3 is going to look and feel very similar. So the MMPI-3 was officially released in 2020. And when you take a look at the technical manual, there was an initial sample of spinal cord procedures candidates, and a comparison group was available at the test launch. The validity data for that is included in Appendix D of the manual. For those of you who really like some technical aspects of things, you can kind of take a look at that there. But there's also a comparison of coefficients between the MMPI-2 RF and the MMPI-3 in Appendix E of the manual. And I'm going to showcase that on the next slide so that you can kind of see what I mean. But what's great looking at those data are that spinal procedure data from Appendix E of the MMPI-3 technical manual suggests that all of the findings from the literature from the MMPI-2 RF can apply to the MMPI-3. So what do I mean by that? So let's take a sample page from Appendix E of the technical manual, and lots of coefficients on this page. So just to kind of give a little bit of a walkthrough, here we have our somatic cognitive scales, and you'll have 2 columns for each. Here's the malaise scale, MLS, and you'll see RF underneath. That stands for the restructured form. And then here's the malaise scale for the MMPI-3. Over here on this vertical column, we have some criteria. So for instance, if we look at the Oswestry Disability Index, and we look at correlations between the malaise scale and the MMPI-2 RF, we get a fairly modest correlation here of about 0.32. When we compare it to the MMPI-3 malaise scale, we get a very similar coefficient size, and we kind of see this all throughout. So for instance, if we take a look at catastrophizing with the self-doubt scale, again, here's self-doubt on the MMPI-2 RF, coefficient of about 0.37. Here's self-doubt on the MMPI-3 with a coefficient of 0.39. Another example, here is current pain interference with the patient's lifestyle. The MMPI-2 RF malaise scale at about 0.24, and the MMPI-3 malaise scale at about 0.21. And we can kind of see this pattern of coefficients be highly similar across both the MMPI-2 RF and MMPI-3. And what was unique when they did develop the MMPI-3 was that they included the expanded item content in addition to the MMPI-2 RF. So both the MMPI-2 RF and MMPI-3 could be scored to allow for some of these comparisons. And so taken together, a lot of the literature from the MMPI-2 RF can be applied to the MMPI-3 in this population. But of course, we have some very specific studies because we also want to make sure that this was properly validated with the MMPI-3. And the first study I want to talk about was published in the journal Psychological Assessment. And it's the reliability and validity of the MMPI-3 scores across patients seeking spine surgery. And in terms of research, the sample comprised of 390 men and 371 women who are seeking some form of a spinal procedure. And when we looked at the means and standard deviations of the MMPI-3 scale scores, they were quite comparable and comparable across gender as well. There were a few small differences that emerged when we compared gender. Notably, men scored slightly higher on some of the behavioral externalizing domain scales, whereas women tended to score a little bit higher on some of the emotional internalizing dysfunction scales and the somatic scales. This is a trend that we saw with the MMPI-2RF. It's one that we see across all the samples in the MMPI-3. And these differences are very small in magnitude. But by and large, these scale scores look fairly similar to what we saw with the MMPI-2RF. When we looked at reliability, we got good reliability sort of across all the substantive scales. Median Cronbach's alpha, for instance, for the higher order scales was about 0.77. For the restructured clinical scales, 0.71. For the specific problem scales, 0.67. And for the Sci-5 scales, around 0.76. So you might look at some of these and say, well, Ryan, the specific problem scale is median Cronbach's alpha 0.67. That doesn't sound that great. And you're right. If you just look at Cronbach's alpha, the thing that you have to think about with Cronbach's alpha is that it's influenced a lot by the number of items that are on the scale. And when you take a look at some of the specific problem scales, I'm going to use the eating concern scale as an example. There's only 5 items on that scale. And when you look at other metrics for reliability, such as mean inter-item correlations, those actually look great. Standard error of measurement looked great as well. And for some other scales, such as thought disorder or psychoticism, there's range restriction there. If just kind of recalling, off the top of my head, it's only around 3% or less of the population even got anywhere close to 65T on the thought disorder scale. And so we get a restriction of range there. And so those are a couple things that you kind of have to think about when interpreting reliability. But by and large, those mean inter-item correlations and standard error of measurement looked very good in those studies. So looking at the correlations between the MMPI-3 scores and the external criteria, what we're kind of beginning to see here, for instance, we have the RC1 scale. This is somatic complaints, correlates fairly modestly with how much pain is interfering with your lifestyle. Another example here is the malaise scale, being even stronger with correlating with pain interference with lifestyle. Another example here is we have another modest correlation between somatic complaints on the MMPI-3 and the Oswestry Disability Index. Some modest to substantial correlation between malaise and the Oswestry Disability Index scores. And then, of course, catastrophizing correlated very well with a lot of the internalizing scales, but the highest with demoralization, followed closely by negative emotionality or neuroticism. And so there was a very clear pattern of good convergent validity, as well as a good pattern of discriminant validity as well. It's not measuring things that it shouldn't be measuring. And so this was a really comprehensive study. There's supplemental material here. So if you really want to go through the nitty gritty of it, this paper is published in Psych Assessment. You can look at all those data. So what does this mean clinically? Scale scores of the MMPI-3 are reliable and valid indicators of psychological functioning among spinal procedure candidates. And when you actually looked at some of the magnitudes of the coefficients and compare them to some of the MMPI-2RF studies, a lot of those coefficients looked as good or better than MMPI-2RF counterparts for a number of those scales. So psychometrically, the MMPI-3 is functioning just as well, maybe a little bit better than the MMPI-2RF. I want to talk about another study as we're kind of maybe thinking about looking towards outcomes. This one is published in the Journal of Clinical Psychology in Medical Settings. And we looked at the incremental validity of MMPI-3 scale scores in predicting 1-year postoperative outcomes across a range of spinal cord surgery and spinal cord stimulator outcomes. So this study was looked at, well, what we have here are correlations between pre-surgical external criteria, and beginning right around here is where we have MMPI-3 scales. correlated with 12-month outcomes. So 12-month pain interference with lifestyle, 12-month Oswestry Disability Index, and not pictured here are a variety of emotional scales at 1-year outcome as well. And what we start to see here, again, here's that somatic complaints, RC1 of the MMPI-3, correlating at about 0.20 at 12 months out in terms of pain level, which is pretty good. And that's actually fairly modest considering that we're looking at a scale from 1 year ago predicting some kind of outcome. Neurological complaints was also a pretty strong correlate here as well. We have somatic complaints correlating fairly well with continued pain interference 1 year after surgery, and the combination of malaise and neurological complaints correlating well with pain interference with lifestyle after 1 year after surgery as well. And same pattern here with the Oswestry Disability Index. We have somatic complaints correlating fairly well there, along with malaise and neurological complaints. And like I mentioned, and due to time, a lot of the emotional scales, emotional internalizing dysfunction scales, RCD, negative emotionality, neuroticism, self-doubt, a lot of the scales correlated very well with a lot of the emotional indicators 1 year out from the procedures as well. The other thing we did is we looked at some hierarchical multiple regressions. So for our dependent variable, we had those 1 year post procedural markers that we entered into the equation as our dependent variable. For the first block of the equation, we added pre-procedural risk factor markers because we wanted to control for those. And after we've controlled for those in the second block, we entered the MMPI-3 scales by scale set to see with whatever variability was left, could these scales predict any kind of outcomes after controlling for pre-procedural markers. And the results of those across analyses were that the MMPI-3 scales accounted for up to 2 to 11% of additional variability in those outcomes after controlling for those pre-procedural risk factors. And as an aggregate, when you take a look at things, scales such as demoralization, that's RCD, somatic complaints, which is RC1, low positive emotions, which is RC2, malaise, worry, anxiety-related experiences, family problems, juvenile conduct problems, and disconstraint tended to fairly consistently emerge as incremental predictors of those outcomes. So kind of taking this together, what does this mean? So the scales of the MMPI-3 can predict suboptimal outcomes up to 1 year after a spinal procedure. And there's a similar paper like this with the MMPI-2 RF. And again, a lot of these results mirrored those that we saw with the MMPI-2 RF. Similar scales emerged, similar amount of variability was accounted for in addition. So again, it looks like the more confidence that a lot of that MMPI-2 RF literature continues to apply here as well. One more study I want to talk about. This one was published in Psychological Assessment. These looked at differences in MMPI, presurgical MMPI-3 scores across trajectories of recovery from spine surgery. This was headed by 2 extremely intelligent and hardworking graduate students. And I just want to give these Emily and Megan a big shout out for this. We had fun with this project. So essentially what we did here was looked at latent trajectory differences among outcomes over the span of 2 years following the procedure. So we had 4 waves of data, and we essentially let the latent class procedure help us determine if there were some clear, distinct trajectories that we could build from these. And then we wanted to use the MMPI-3 scale scores to identify those who had less change over time or maybe worse change over time. And so there were data available for about 400 patients, and it was pretty evenly split between men and women. And the 3 trajectories that came out as pretty well delineated are pictured here. And just to give a walkthrough here, on this axis, the y-axis, we have Oswestry Disability Index scores. So 0 means that pain is causing them no disability whatsoever. 100% would mean that their pain is causing them 100% disability. This solid black line here represents a group that we call the persisting disability group. You'll notice they started fairly high, and they didn't change that much over the course of 2 years. Compare that to this dotted line, which is our steady recovering group. They started a little bit lower than our persisting disability group, but they gradually changed over time. They got better over time. And then we had these dashed lines here, which represent a rapid remitting group. And these were folks who, after surgery, had a very quick diminishing of their disability related to pain, and were able to maintain that up to 2 years after surgery. So overall, at least with these data, we were able to find two groups that had some pretty good trajectories for outcome, but we want to see, do MMPI-3 scale scores, are they associated with this persisting disability group? So another big table, just try to highlight some things here for everybody. So here we have some of the MMPI-3 scales. And here we have means and standard deviations of those scales for the rapid remitting group, the steady recovering group, and the persisting group. And here we have mean differences between the two, and things that are in bold are statistically significant. So for instance, here is demoralization. When we compare the persisting group to the rapid remitting group, these folks tend to score substantially higher on demoralization. They tend to score higher on somatic complaints. Low positive emotions, dysfunctional negative emotions, malaise, neurological complaints, and a few others, but one that was really strong was the anxiety-related experiences. And so it looked like the MMPI-3 pre-surgical scale scores did a pretty good job at being associated with this persistent unremitting group over time. And so taken together, a lot of the inferences that we were able to draw from those short-term studies using the MMPI-3 scales as predictors extend as far out as 2 years following spinal procedure interventions. And MMPI-3 scales tend to be associated with patients who tend to have less change over time with regards to their pain, functional disability, as well as their negative affect. So there's more research underway, of course, but I want to turn our attention over to a case example where we're also going to showcase the MMPI-3 spinal procedure candidate interpretive report and give everybody a nice walkthrough of how those reports look, how they're different, and yeah, we'll go from there. So this is the case of Mr. F. He's a single 55-year-old man who was injured at work. He was carrying a heavy toolbox and had stepped into a hole, sort of lost balance and twisted himself abruptly to catch himself. After that event, he started having low back pain as well as leg pain. Went through a series of conventional treatments, including physical therapy and steroid injection. And despite conservative efforts, I was not experiencing any kind of pain relief. So was referred for a pre-surgical psychological evaluation prior to surgery. And his hope and what he talked with the surgeon about was to have a spinal fusion at L5-S1, so very, very low back. And so that's what our evaluation is based on. So during the psychological evaluation, he reported that his pain was an 8 out of 10 at the time, and that it had progressed to develop some numbness and weakness down his left leg. He was receiving workers' compensation, which only was 70% of his base pay, and he reported significant financial difficulties due to the loss of income. He reported quite a bit of depression and also appeared to be quite demoralized during the evaluation. In addition to feeling depressed and being viewed as demoralized, he also reported feelings of hopelessness, not having any energy anymore, lots of anxiety about what his future would look like, and that he was beginning to withdraw from various family members and family events as well. Medication regimen included taking hydrocodone, about 10 milligrams 2 to 3 times per day for pain, and alprazolam for sleep at night. His pain was also interfering with his ability to sleep. And so this is, we're going to walk through the MMPI-3 spinal procedure candidate interpretive report. At least on its cover page, it looks very much like the standard MMPI-3 score and interpretive reports. You'll know it's the spinal procedure candidate report. It'll name it here. You have your demographics that you entered into Q Global here, as well as the date that the MMPI was administered. And then the next page are the validity scales. And for the spinal procedure candidate interpretive report, you would interpret the validity scales as you traditionally do. There's not a whole lot of changes there. But one thing I want to start drawing your attention to as we're going to look towards the substantive scales are these comparison group data that are going to appear. So we're going to start comparing our candidate scores to those of the comparison group. Visually, you can see the means and standard deviations here on the profile. So this gray box represents essentially the standard deviation of the comparison group, with the white dot representing the mean. But looking at the T-scores here, well, first, they endorse all the item content. In terms of inconsistent responding, everything looked okay here. In terms of over-reporting, across our over-reporting scales, everything looks okay here. And we don't have any concerns about under-reporting at all. So again, we would interpret these just as we have traditionally done. Things get a little different when we move to the higher order and restructured clinical scales. So one thing that you can start seeing is, at least in terms of our comparison group data, that our candidate does produce scores that overlap quite a bit with some of the comparison group, but some scores that are quite discrepant as well. And so we draw our attention back down here to the comparison group data. And let's use demoralization as an example. We notice quite a discrepancy here. One thing that we note is that this patient is scoring at, or 98% of patients score at or below this T-score of 65 in this population, meaning that only about 3% of patients are scoring at or above 65T, making this a fairly unusual phenomenon to happen. And so we're gonna be paying attention to this, and as we continue to move forward in the report. And so this kind of gives you a good idea, sort of across your profile, how much your patient differs from the comparison group. Taking a look at the specific problem scales, we'll start with somatic cognitive and the internalizing scales. Again, we're going to take a look at our comparison group data. And we see that there's a few scores that have some small discrepancies, and some of these our candidate produced scores that have quite a bit of large discrepancies with those generated in the comparison group. And so we're definitely going to want to take a look at that. But again, I want to draw your attention to another phenomenon that happens in these reports. So this is the anxiety-related experiences scale. And traditionally, one would begin interpreting a lot of these scale scores at 65T or above. We notice there's quite a bit of discrepancy here in this patient's score relative to the comparison group. Their T-score is a 62, but notice that only 3% of patients are scoring at or above 62T, meaning that 98% of patients are going to be scoring at or below 62. So this is something that we're going to want to pay attention to, and something that's integrated within these spinal procedural candidate interpretive reports are interpretations of more differential cutoffs. And this is one way that you can begin drawing your attention to that. So you can see it visually here. You can also see it displayed down here in the comparison group data. But a 62T on anxiety-related experiences is uncommon, and something that we're going to want to pay attention to. So again, we continue through the report, and it very much looks the same to the interpretive and score reports. We'll pay attention to our comparison group data down here, looking at some of these discrepancies here as well. And then we get the Psi-5 scales here. Again, just to illustrate, we have this patient scoring higher than a lot of folks in the comparison group. We may want to pay attention to something like this. When we come to the summary sheet, where we look at the scale scores by domain, What's nice about these interpretive reports are that they're going to be bolding the scales that are going to be interpreted within the spinal procedure candidate sections of the report. So you'll see emotional internalizing dysfunction at 61T. Traditionally, we want to look at 65T, but with spine surgery candidates, we're going to look at it at a slightly lower cutoff. Here's that anxiety-related experiences scale we looked at a couple slides earlier at 62. That's bolded. Negative emotionality is bolded. And so this summary sheet kind of gives you a good idea of what some of these scales are and when we need to start interpreting them. And you'll notice that for a lot of these scales, notably the emotional internalizing dysfunction and interpersonal scales, we're going to want to start interpreting those at lower cutoffs. So moving forward with the interpretive report, so you will see here a brief synopsis here that's going to let you know that the comparison group findings point to possible concerns about emotional problems, including unhappiness and dissatisfaction, suicidality, self-doubt, inefficacy, negative emotion, stress, worry, anxiety, family conflict, and interpersonal problems. And there's possible pre-procedural risk factors associated with demoralization and depression, pain coping, health orientation and medical adherence, anxiety and stress, fear avoidance, interpersonal, and substance abuse domains. The next section, which is just protocol validity and substantive scale interpretations, these are going to be taken directly from the interpretive manual. So there's going to be nothing different in these next two sections that you don't already get with the interpretive reports. So when we look here, for instance, it's going to be interpreting those scale scores where it's recommended that they're interpreted in the regular interpretive manual. So you'll see here that there's also, it's a little difficult here to see on the webinar, but there's some citations here as well. So you're able, for each of these statements, be able to see in the literature where that's coming from. We have our diagnostic considerations here as well. And so generally speaking, if you're using interpretive reports, it looks and feels very much like the standard interpretive report. So you get that in the output. Now where things start to deviate a little bit are these comparison group findings. So this is going to look at these scales and determine whether or not there's some unusual patterns relative to the comparison group that we're looking at. So turning to the next page, we see, we'll notice even the stark difference here, the emotional internalizing problems section when interpreting scores relative to other spine surgery candidates is a little bit larger than what we saw on the other page. So if we kind of take a look here, so this is for demoralization. We see an interpretive statement here. More specifically, his responses indicate feelings of unhappiness, dissatisfaction, and being overwhelmed that may negatively affect spinal procedure results. And a citation there, if you're looking to see where that statement comes from. A follow-up statement that this level of demoralization is very uncommon among this population. Only 3% of comparison group members give evidence of this or greater level of demoralization. So it's taking that comparison group finding that we saw that only about 3% of patients scored at or above that cutoff, and it integrates it into this summary. And it does that for each scale that tended to deviate from the mean and standard deviation of the comparison group. And so we'll get those by domain, just like we do with the standard interpretive report, but it's going to be language specific to spinal procedure candidates. The next section of the report are pre-procedural psychological risk factors. And so these are going to integrate those scale scores that we got to empirically linked diminished spine surgery results. And it's going to not categorize them, but organize them across 9 different domains. So for instance, one of the domains is demoralization and depression problems. Compared with other spinal procedure candidates, the patient is more likely to be experiencing depressive affect and to have low energy levels and feel exhausted. So again, you can look up those interpretations and where those were pulled from. Again, it's a little difficult to see the citation there, but you're going to be able to take a look at that citation. We have another domain here, pain coping problems. So compared with other spinal procedure candidates, this patient is more likely to catastrophize when experiencing pain. They're also less likely to be less self-reliant. We get those for health orientation and medical adherence problems, anxiety and stress problems, fear and avoidance problems, interpersonal problems, substance abuse problems. And if they didn't trip anything in some of these domains, these would be listed here. So this patient had no risk factors associated with pain and somatic sensitivity problems or recovery disincentive problems. We also have predictive statements here as well in the procedural outcome section. So again, these are based on empirical correlates and some of the prospective studies that some of which we talked about today. Now, this doesn't necessarily mean that the patient's going to have this kind of outcome, but they are more likely to have these kinds of outcomes. And so it'll list what these will be. So compared to other spinal procedure candidates, post-procedure, this patient is likely to report higher levels of pain, greater levels of disability, experience more negative affect and higher levels of psychological distress, taking Schedule II opioid medication, not returning to work, have lower levels of satisfaction with the results of the procedure, convey strong negative feelings that the procedure results did not meet those expectations, and report a more negative overall outcome. And so again, it doesn't mean that the patient's going to experience all of these things after the procedure. Of course, part of our job is to try to mitigate that if we can before the patient goes for surgery, maybe shortly thereafter. But certainly something that can draw our attention to these things. And then, of course, we have our treatment recommendations. So these are going to be specific to spinal procedure candidates. So for instance, helping the patient recognize positive aspects of his situation and focusing on each improvement, however small, may help build momentum. And different kind of interventions that may help him identify strengths, despite problems that develop techniques for countering negative self-evaluation may improve procedural results. So again, these have some citations embedded within them, but it's going to help guide treatment. So if you do have an opportunity to work with the patient prior to the procedure or shortly thereafter, it's going to help guide you to what needs to be targets for those interventions. We then get, of course, the item level data. But one thing that's also unique to these reports that I cannot show you what these items are due to test security, but we've had a panel of experts who do pre-surgical spinal cord and spinal stimulator evaluations, go through the MMPI-3 and looked at what they called critical items that maybe isn't contained specifically in a scale summary, but that it should be really important to look at to follow up with your patient at the end of the evaluation. We have those endnotes where it shows what tripped the scale as well as the references associated with those elevation levels. And then you'll get a printout of all the references. So if you are interested in looking at where some of these scale interpretations came from, you can certainly find those there as well. And you'll see that even within the references that you'll see a lot of our research popping up there as well as others. So that's about all the time I have to talk about the reports. Like I mentioned, I tend to be a pretty approachable guy. I'm really responsive. You are always welcome to contact me via email. You're welcome to give me a call on my office phone. I'll get your phone call even if I'm not in the office. But email is the preferred method of contact. I'm always open to doing research as well. So if there's something that if we haven't been able to answer yet with the spine or spinal cord stimulator populations, I always tell folks it's an empirical question. So let's see if we can find a way to answer that question. But we have about 5 minutes left, and I do want to give an opportunity for maybe a few questions. And if your question doesn't get answered or you don't want to put your Q&A in the box, by all means, feel free to reach out to me.
Excellent. Thank you so much, Dr. Marek, for that wonderful presentation. Yeah, they are flowing in now, so we'll get to as many as we can. The first one up, someone was mentioning the correlation of 0.2 is usually considered to be kind of weak, but was presented as meaningful, I believe, up in your table 5 that you had up before the case studies. Did you want to have any comments on kind of why you might have highlighted those?
Yeah, so yeah, I think traditionally in graduate school we learn all about correlation magnitudes, and oftentimes when we see correlations of 0.2, 0.3, let's not forget that those are actually equivalent to close to medium effect sizes. Like if you were to convert them into Cohen's d, for instance, a 0.3 correlation is equivalent to about a 0.5 Cohen's d value. And so you also kind of have to think about what the criterion is. We're not looking at, for instance, two pain measures. We're looking at, for instance, malaise with pain interference with lifestyle, for instance. So construct related, there's some overlap there, but it's not a clean overlap either. And when we're even thinking about outcome, for instance, the fact that a scale could be associated with an outcome as far as 1 year out from the procedure, that's pretty telling considering all the other additional aspects in terms of what could be accounting for that patient's score there too. So they're not going to be perfect correlations. We're not looking for perfect correlations. If they were perfect correlations, I'd be a little suspicious. But yeah, generally speaking, when we look at a lot of these correlations in behavioral medicine, we're looking at about the 0.2, 0.3 range is typically what you tend to see.
Excellent. Thank you so much. The next one up. Are the comparison groups successful implant patients? And also, how would you phrase less than good candidates in your report writing? And do you have any sort of cutting percentages that you use?
Okay, so in terms of the comparison group, it's just that it's a comparison group. So they're not healthy comparisons, right? So they're not folks who are in. We didn't collect these data and they have great outcomes, and thus they're included as comparison groups. So the folks in the comparison group have had ranges of outcomes, some very good outcomes, some not so good outcomes, and so it's really as close as possible to a true comparison of most folks who are coming for a pre-surgical psychological evaluation. The other part of that question, actually, Ben, would you mind repeating that second part of the
Absolutely. Sorry
question?
I should have broken those up. How do you phrase less than good candidates? And do you have any sort of cutting percentages that you use?
So, I think any kind of language that you're writing in your report, such as less than ideal or suboptimal or risk for suboptimal outcome, I think all of those terms I think are fine to use. There are some algorithms that have been developed. I know for sure there's one that includes the MMPI-2 developed by Andrew Block that uses various kinds of language, including things like excellent, fair, outcomes, things like that. So there's other ways that you can kind of temper that language if you would like to. So there's no gold standard or agreed upon term that I'm aware of.
Excellent. Thank you so much. Do you recommend that any additional measures be used in conjunction with the MMPI-3?
Yeah, so absolutely. So there's obviously lots of good measures to use, and if you're somebody who accepts insurance, you have to include at least two psychological tests. So something like with this population, because pain is so central, something like the Battery for Health Improvement 2 would be a great test. Something that I always like to think about is if I'm going to have to give something else, what could be additive to something like the MMPI. And so something like that could certainly be additive. And then maybe some other shorter measures like the Oswestry Disability Index or maybe the Pain and Impairment Relation Questionnaire, something that maybe is more specific content-wise, but something that you can maybe also administer over time. So if you are doing, for instance, cognitive behavior therapy prior to the patient going for surgery, you can actually maybe be able to look at some measurement-based care there to demonstrate to the surgical team that with psychotherapy, for instance, that your patient was able to improve a little bit. So I always recommend not just doing an MMPI. Definitely find something that's additive in your evaluation that's going to help you do a good conceptualization of the patient.
Excellent. Thank you. And I think we have time for just one more, and then we will let everyone go. There was a couple questions about sort of the lower T-score cutoffs from 65. And did you want to kind of touch on some of the rationale for that again for some people?
Yeah, so we looked at frequency data for these samples, and we looked at we have a few studies. I didn't go over them where we actually looked at the differential cutoffs as well, to predict some of those outcomes. And so we use a combination of how many patients are actually scoring at various cutoffs, in addition to some empirical risk statements as well, risk analyses. And we sort of derived that for some of these scales, that a slightly lower cutoff than 65T, and in some cases a slightly higher cutoff. For instance, some of the somatic scales were more appropriate than just keeping everything at 65T.
Excellent. Well, thank you so much for taking the time and providing all this wonderful information. If you have anything else left to share, do it now. Otherwise, I think we will be done for the day.
No, I thank everybody for their time. And like I mentioned, always feel free to reach out.
Excellent. Thank you so much.